If you spend any time on social media lately, you've probably heard the word Retitrutide. We get a call or a text every day asking if it's something that we offer. And so today I'm going to slow this way down and do it right. This is not hype. This is not fear-mongering. This is just how adults talk about powerful biology. All right, Landon, hit the disclaimer. I want to start by saying we cannot legally or ethically offer Retitrutide right now. There is no FDA-approved Retitrutide. There's no legitimate pharmacy carrying it, no regulated supply chain. So anything labeled Retitrutide online is under the research chemical status. And that matters. When these compounds get sent for third-party testing, like if you buy it from one of the online sites listed as a research chemical and you send it to a company who will test it for purity, dosing, really all that stuff. When they are sent, we are seeing incorrect concentrations, massive dosing variability, positive for endotoxin contamination. And sometimes it's not even the compound being advertised, which is not great when the delivery method is inject this directly into your body. You're trusting sterility, synthesis quality, dosing math, and honesty from a system with zero oversight. There's no FDA, no inspections, no accountability. This could literally be a guy making it in his bathtub and bottling it up and sending it to you. You're just trusting that this guy also knows how to do math and knows how to maintain appropriate sterile technique. But just to be clear, the website looked professional, has never once been an FDA-approved safety metric. So when we say we won't prescribe it, what we really mean is we're just not willing to experiment on it. But let's talk about what it is. It is amazing, and so I am super pumped, so I do want to dive into it a bit. Retitrutide is a once-weekly injectable triple agonist. That means it activates 3 hormone receptors, GLP-1, GIP, and glucagon. This is fundamentally different from older weight loss drugs. It's not caffeine, this isn't amphetamines, this isn't just eat less. This is metabolic signaling. Think less diet pill and more corporate takeover of your appetite department. So let's break down the triple agonism with this med. So GLP-1. GLP-1 is kind of the appetite brake. It increases satiety, which means it makes you more full, reduces food noise, improves insulin signaling. And so this is why patients with GLP-1 meds say, I just stopped thinking about food. GIP is the signal amplifier. GIP doesn't do much alone, but in combination, it improves metabolic efficiency, enhances insulin sensitivity. And so it's not flashy, but it's definitely supportive. GIP is the guy at work who doesn't talk much, but once he shows up, everything seems to work better. So GLP and GIP is what tirzepatide, Mounjaro, Zepbound is. Retitrutide is the same, except it adds glucagon. And adding glucagon seems to activate this metabolic furnace. Glucagon increases energy expenditure, fat oxidation. GLP-1 lowers intake. Glucagon increases burn. And so that's why this combo is hitting much harder than the other ones. You're not just telling your metabolism you're on a diet, you're now on a performance improvement plan. So phase 2 trials, it is still going through all the appropriate trials, that they were on average 24% weight loss at 48 weeks. So that's higher amount of weight loss than tirzepatide in a faster time span. Phase 3 is showing even in the high 20% around 68 weeks. That outdoes some of the bariatric surgery procedures. I mean, it's very understandable why the internet all of a sudden went, cool. Where can I get this illegally? So why is it not approved yet? And it's not because it doesn't work. It's because the FDA, whether what we think about the FDA these days, but they still want long-term safety. They want cardiovascular data. They want manufacturing consistency. And that allows us to see the adverse effects that are happening at this time. What is happening is GI side effects that we know with other GLP-1s and everything. Heart rate related changes from the increase in metabolic demand is going to raise heart rate a little bit. Gallbladder risk from the rapid weight loss, and can happen with any rapid weight loss method, whether it's bariatric surgery, any other current meds, or just even naturally, if you lose weight too fast, it just kind of makes your gallbladder sluggish and can back up. Retitrutide has also some skin dysthesias, meaning that it can have weird skin sensations with the higher doses, and this is what's been reported so far. None of this is really shocking. If losing 25% of your body weight didn't have side effects, that would probably even be more concern. But I am just super pumped for 2026 as a whole for weight management. We have been extremely limited on weight loss medications for years. And really now the only things that I see really make a difference are phentermine, topiramate, semaglutide, tirzepatide. So, I mean, 4 meds and 2 of those are pretty much together. But there are several more things in the pipeline. And it's going to be amazing to have options that can all significantly impact weight management. We're no longer asking, how do we force weight loss? We're asking which biological levers control hunger, fullness, burn, and how do we stack them? How do we combine them? What ratios do they work best? So let's just talk with one. It's even already out today is oral Wegovy. Oral semaglutide has been around, which is Rybelsus. It just was super underwhelming in terms of weight loss. It had some glycemic control, but from weight loss, just never really panned out well. Struggled because absorption was inconsistent, exposure is too low, and the oral Wegovy fixes that with higher dosing and better exposure. So the result is 13 to 16% average weight loss. The trade-off with this is that strict morning rules. It's basically a pill that says, don't look at food, don't think about food, and don't drink that coffee yet. I think it's going to do okay. One, you have to work up the dose pretty high, and so it takes ramping up. And side effects are typically more than what the injections are. So if you didn't tolerate even low-dose injections, I'm going to be pretty hesitant to put you on this and try and work it up. But, it's just nice to have another option to try. We'll definitely try whatever we feel works best. That's Novo Nordisk oral weight loss med. Eli Lilly's is orforglipron. Yeah. Let's try that again. Orforglipron. I'm still going to have to keep practicing this. Orforglipron GLP-1 is an oral GLP-1 without the gymnastics of oral Wegovy. The biggest gymnastics aspect is how to say it. And I'm hoping the internet comes with a faster slang that I can say orflorg, or I don't know. Until then, I'll just continue to practice in the mirror. I obviously still need practice. And so this is one that I think will quietly reshape obesity treatment overall. Orforglipron is not a peptide, which is a big deal because the peptides are digested easier. They're just sequences of amino acids like protein that are rapidly dissolved in stomach acid. So this is classified as a small molecule GLP-1 receptor agonist. And so that's a pretty big deal because that means it now survives the GI tract. It's absorbed consistency, and it doesn't need special timing. You can take it with food, without food. You can take it morning, at night. In terms of obesity management, this matters a lot because we are really working on adherence and consistency. A slightly less potent drug taken consistently will beat a stronger drug taken inconsistently every time. So real-world medicine is not a clinical trial. Orforglipron shines because there's no fasting ritual, there's no absorption anxiety, no did I mess this up stress, and patients were very consistent in the studies. And so average weight loss was 8 to 12% over 72 weeks, depending on dosing. A little bit more than like the combination phentermine topiramate, but just better tolerated overall. The next one in the pipeline is cagrisema, and this kind of introduces us to amylin. This is cagrinolitide and semaglutide together. The cagrinolitide is an amylin component, and amylin reinforces fullness, it ends meals, and reduces food reward. So GLP-1 with the semaglutide says, you're not hungry. The amylin component says, we're done. GLP-1 turns the volume down. Amylin takes the remote and removes the batteries. Average weight loss is 20 to 23%. Downside is higher GI side effects. Yes, because biology is still biologing in terms of absorption with these. Another one that is kind of in the pipeline is Survodutide and Amycretin. And Survodutide, again, I'll need to practice these a little bit more before we're saying them routinely throughout the day. But that's kind of like an appetite break plus a bit of a metabolic burn. And the Amycretin is a GLP-1 plus amylin in one molecule. Huge early results, but GI tolerance is still the limiter. Basically, the future is stacking hormones like Legos and hoping your stomach doesn't file a formal complaint. So the biggest takeaway is there's never going to be one perfect weight loss drug, but man, it's going to be amazing to have options. I have no idea what pricing looks like for any of these. I'm hoping they're more entry level than how the GLP-1s have been. They're coming down, but they're still cost prohibitive for most, and insurance still just drags their feet in trying to cover, and They make us jump through hoops to even try to attempt coverage. But more competitors in the market has me optimistic that this is going to be overall more cost effective. The future is matching biology to biology, layering in mechanisms intelligently, and prioritizing safety. Retitrutide isn't magic, but it is powerful biology. Until it's approved, don't inject mystery powders, don't trust sketchy sources, don't confuse hype with medicine. And I promise once this is approved and you're not having to check out by paying with Bitcoin, I'll be trying it myself. Until then, go do something your hormones will thank you for. Sleep, lift something heavy, go outside, and I'll see you in the next one.